Bismillah ar-Rahman ar-Rahim. Our subject today about cholera with you, Dr. Nasser Muhammad Abdullah, Professor of Tropical Medicine, Alexandria University. We start first by definition of cholera. Cholera is an acute diarrheal illness caused by Vibrio cholera involving the entire small bowel. Cholera is considered as the most feared epidemic diarrheal disease because of its severity, as dehydration and death can occur within a matter of hours of infection. Although cholera can be life-threatening, it is easily prevented and treated by advanced water and sanitation system. The patient gets infection by cholera through ingestion of hydrogen and seafoods and other foods contaminated by excreta of patients with symptomatic or asymptomatic infection. The risk of severe cholera infection increases with reduced gastric acidity as the use of antacids, histamine receptor blockers, proton pump inhibitors, as well as patients with H. pylori associated gastritis and in patients undergone a gastrectomy. The pathogenic strains of Vibrio cholera 01 and 0139 are associated with epidemic cholera. Vibrio cholera 01 is classified into two major biotypes capable of production of severe disease: classic Vibrio and Tor Vibrio. Currently, Tor Vibrio is the predominant cholera pathogen. Both we have two biotypes of cholera, Tor and the classic. Each one is differentiated into three major serotypes: Hikujama, Inaba, Ogawa, and Hikujama, Inaba, Ogawa, and each serotype has different antigens. All these types, biotypes, serotypes, antigens must be included in the diagnosis of Vibrio cholera infection. What about the clinical picture of cholera? The incubation period is short, ranging from 1 to 3 days. It varies with host susceptibility and inoculum size of infection, and can range from several hours to 3 to 4 to 5 days. The clinical picture varies from subclinical, mild, uncomplicated diarrhea, and fulminant lethal disease. What about the age of cholera patients? All ages are susceptible to infection, although infants are protected through maternally transmitted antibodies during breastfeeding. In high endemic areas, the incidence is highest in children less than 5 years due to lack of protective immunity. An attack of the classic biotype of Vibrio cholera usually protects against recurrent infection by either biotypes, Tor and the classic. But infection with Tor cholera does not protect against further attacks of cholera infection. The patient is presented with abrupt onset of painless diarrhea, watery in type, associated with vomiting. Fever is uncommon, so the presence of fever in cholera patients should consider a concomitant infection or complication. The patient might have mild degree of elevated temperature if he develops severe dehydration, and it's called dehydration fever. But it's mild degree of elevation of temperature, not so high. Bloodstream invasion by the organism is rare, so we have no bacteremia and no septicemia and no systemic manifestation in patients with cholera. Approximately only 5% of infected persons has severe disease. Without treatment, death can occur within hours of infection, so cholera patient must be diagnosed very early in the course of infection, even on suspicious. Severe cholera is characterized by profound fluid and electrolyte losses in the stool with rapid development of hypovolemic shock, often within 24 hours from the initial onset of vomiting and diarrhea. So, Early rehydration therapy reduces the mortality of severe cholera from over 10% to less than 0.5% of patients. The presentation of cholera is mainly diarrhea. In mild cases of Vibrio cholera infection may be clinically like other causes of diarrheal illness. The profound and rapid loss of fluid and electrolytes mark severe cholera as clinically distinct entity. Cholera stools may contain fecal matter and bile in the early phases of the disease and usually contain a higher concentration of sodium, potassium, and bicarbonate. The characteristic symptoms of severe cholera, what's called cholera gravis, is the passage of profound rice water stool, a watery stool with flakes of mucus. It typically has a fishy odor and usually painless without tenesmus. In adults, stool output can reach as high as 1 liter per hour in the most severe cases. In children, the maximum rate is typically between 10 and 20 centimeter per kilogram per hour and is not typically observed in other diarrheal illness. The total volume loss over the course of the illness may up to 100% of the body weight. If these patients are treated with proper rehydration, diarrhea is most severe during the first 2 days and ends after 4 to 6 days. Other gastrointestinal manifestations of cholera include vomiting, which is frequently with watery emesis, and it is common and may begin either before or after the onset of diarrhea. So patients may have also abdominal cramps due to the rapid loss of fluid and electrolytes. What about the complications of cholera? As we mentioned, it is a diarrheal disease. The main presentation is diarrhea and the main complication is dehydration. Complications are related to the volume and electrolyte loss from diarrhea. Severe hypovolemia may occur within hours of the onset of symptoms. So patients are frequently apathetic and lethargic. They are presented with intense thirst, oliguria, muscle cramps due to loss of electrolytes, weakness and marked loss of tissue texture with skin sunken eyes and wrinkling of skin on fingers. Manifestations are due to loss of isotonic watery stool rich in sodium, chloride, bicarb, and potassium. This figure represents a patient presented with severe dehydration. So, the spot diagnosis is a dehydrated patient. The first step in the management is rehydration with suitable fluid and electrolyte institutions, whatever the cause of the presentation. Another complication of cholera is metabolic acidosis. It results from loss of stool bicarbonates as well as lactic acidosis from proper perfusion, may result in cosmal breathing, which is deep respiration reflecting compensatory hyperventilation. The peripheral pulse is rapid and thready initially, and it may become difficult to palpate as blood pressure drops. Also, muscle cramp may occur and weakness due to loss of potassium and calcium are common. Another complication is the form of renal failure due to acute tubular necrosis, which may occur as urine output decreases. Also, hypoglycemia may occur in patients with cholera infection, especially in children, due to depletion of glycogen stores and inadequate gluconeogenesis, which can lead to symptoms of severe hypoglycemia. Another complication is pneumonia, which is frequent comorbidity among patients with cholera due to vomitous aspiration and has been associated with mortality. Cholera Zika syndrome is a unique entity in cholera patients, which is an unusual form of disease as fluid accumulates in the intestinal lumen with the result of circulatory collapse, and even this can occur in the absence of diarrhea, and this is clinically rare entity. In general, if appropriately treated, cholera has no long-term complications. However, chronic enteropathy, and malnutrition can result in young children. Another complication is the development of chronic biliary carriers in cholera patients. What about the mortality of patients with Vibrio cholera infection? The mortality rate of cholera in untreated patients may reach to from 50 to 70%, and this would be reduced to less than 0.5% if adequately treated. The mainstay treatment is rehydration with isotonic saline solution and electrolyte. The mortality risk is increased in children in endemic areas 10 times greater than in adults, as well as in cholera during pregnancy. What about the diagnosis of cholera? We have two methods of diagnosis: clinical diagnosis and laboratory diagnosis. The clinical diagnosis of Vibrio cholera infections, this would be suspected in patients who present with severe acute watery diarrhea without tenesmus, with or without vomiting. So the key of presentation is the development of acute watery diarrhea. There is no fever, there is rapid and severe volume depletion, and the WHO organization says that cholera should always be suspected when a patient 5 years or older develops severe volume depletion from acute watery diarrhea, even in areas where cholera is not known to be endemic. In endemic areas, cholera should be suspected in patients 2 years or older with severe acute watery diarrhea. The differential diagnosis of case of cholera: there is a variety of pathogens can cause acute watery diarrhea. This ranges from rotavirus and Clostridium infection, enterotoxicogenic E. coli. There are no signs or symptoms that can clearly distinguish cholera from other infectious causes of severe watery diarrhea. However, suspicious for cholera should be raised if watery diarrhea is accompanied by severe and rapid volume depletion or occurs in outbreak setting. This table represents the most common pathogen causing diarrhea in adults in the developed world. Acute watery diarrhea may result from enterotoxicogenic E. coli, Vibrio cholera, norovirus, Campylobacter, and another organism, where this to be differentiated from acute bloody diarrhea, which mainly caused by Shigella, Campylobacter, enteroinvasive, enteroaggregative, enterohemorrhagic E. coli.